Right, one of the things that happens really quickly to neonates is when you're ventilating them, it's easy for some alveoli to rupture and some air to start leaking into the pleural space and give them a pneumothorax. And it can happen pretty quickly. So when you start suspecting that something's not right, you don't see good chest movement, they're desaturating, blood pressure's down, you don't really have time to call for a stat x-ray, have x-ray come, take the x-ray, and then finally it shows up on the computer. So is there a quicker way to diagnose if the patient's had a pneumothorax? And the answer is yes, and it's called Transillumination. And it's basically a flashlight that you hold up to the chest. And when you hold a light up to the chest and the lung tissue is normal, the light won't shine really bright. It'll show the chest, but it won't be a bright light. However, if there's a pneumothorax and the chest cavity fills with air, when you hold the flashlight up to the chest, it's very bright. It's hyperlucent is the word that's used. So that's what this slide is talking about. So to quickly diagnose a pneumothorax, a bright light is held up to the infant's chest. You place the light probe on, pardon me, on the anterior chest, first on one side and then the other. If you see a normal light, it's called translucent. But if you see hyperlucency, like the light is really scattered easily and it's bright, that's called hyperlucent, and that indicates a pneumothorax. So what is the treatment for a pneumothorax?
Chest tube.
Yes, very good, a chest tube. And did you have to learn placement of the chest tube? Like, do you put it on the under the armpit, lower down on the ribs? Do you put it in?
Yeah.
Mid-axillary? Mid-clavicular maybe?
Sorry.
Yeah, so air likes to rise. When there's pleural fluid in the pleural space, you put a lower chest tube, but air likes to go up, so you put the chest tube up higher. All right, next we talk about the Dubowitz or Ballard scale for determining gestational age of a newborn. And I gave you a handout that pertains to that. When an infant is born, they can be born prematurely and be developed normally for that premature state, or they can be born prematurely and still be underdeveloped for what they should be at that weeks of gestation. So there's testing done on the newborns once they're born. Do I have one? And just to tell you really quick, so what you'll need to know is what Dubowitz testing is for. It's called Ballard. I don't know why. There's no relation to the Ballard for suctioning. I guess Ballards are just famous for other things. So it's called Dubowitz testing or Ballard testing, and it's testing for gestational age. So on the top right, it says gestation by dates. So according to mom's history and the time of the last menstrual period, you can figure out how many weeks of gestation the pregnancy was. So that's using mom. Then the infant is put through some testing, and from that you can come up with the actual gestational age. So for neuromuscular maturity, physical maturity, depending on how the infant postures, when they're really premature, like 24, 26 weeks, you don't see the arms coiled or the legs coiled. They're kind of flaccid when they're really premature. So that can be an indicator of their gestational age. Bending the wrist, looking at arm recoil, looking at their legs, pulling the arm across the chest. All of this comes up with a neuromuscular maturity rating. And then below that it says physical maturity. So you look to see if the skin has developed, or if it's, when they're really premature, the skin is transparent because it hasn't developed yet. They won't have any hair on their body. The heel, instead of it having wrinkles like a newborn baby, it'll be pretty plain. Breasts won't be developed. The eyes and the ears They won't be developed. I think I have some pictures of this. Yeah, so premature, you notice how the legs and the arms are not coiled up or flexed, that they're held straight. You can tell this is full term or like a 38, 40 week gestation because the arms are flexed and so are the legs. I don't know what I'm showing you on this picture.
Just the flexing maybe? Another flexing.
Yeah. And then a wrist of,
Whoa, they're bending.
you would think the opposite, but the more the cartilage develops, the tendons develop, they can be bent in a full term, but not so much when they're premature.
I cannot.
Premature baby, you can pull the arm straight across, but in a full term, it only goes part of the way. Looking at the bottom of the foot, you see lots of wrinkles in the full gestational age, but not so in premature. Full term, you see the pinna of the ear is folded under, so it's more developed, and it's really thin at an earlier gestational age. No, let me just use that light for a minute. All right, so on this form, that's what they do. They come up with a number, a scoring, and depending on the scoring, they can tell you what the gestational age is. All right, on the back of this, the infant is measured, their length is measured, the head circumference is measured, their weight, and from that, you look at it on the chart. And if they're, let me give you some examples. In the back of the form, for head, no, what's the first one? Length?
Yeah.
Write in 31 centimeters. For head circumference, write in 21 centimeters. And for weight, write in 574 grams.
And these are our norms?
No, I want you to tell me if the infant is large for their gestational age, if it's appropriate for their gestational age, or if they are small for their gestational age. And the gestational age is, I have to give you a number, 24 weeks. No, I have to give you something on the graph. How about 27 weeks? So do you see on each box across the top, it has the week of gestation? So find 27 weeks, and then go down and put a dot at the number that I gave you. So for the length of 31 centimeters, put a dot, go down from 27 to you see 31 centimeters and put a dot.
Oh, I see.
And then for head circumference, 21 centimeters. So find 27 weeks of gestation at the top and go down to 21 and put a dot. And then do the same thing for the weight. The weight of 574 grams, find 574,
Yeah.
and no other dots. Just the 574 and put a dot.
Everything is just right below everything.
Yeah.
Not even on the mark, the lines.
Yeah, so where the lines, in between the lines is normal. Outside of the lines, if you're above the lines, it's large, and if you're below the lines, that's small. So what do you come up with for this state?
Small,
Yeah.
definitely small.
So born prematurely, but even for that 27 weeks of gestation, they're still smaller than normal. So probably it was a problem with the placenta supplying blood flow to the fetus, so they didn't develop like they should have, obviously, and then they were born prematurely on top of it. So you would say they're small for gestational age. That's the conclusion that we came to. All right, so what you need to understand from this is that the name of the testing, it's Dubowitz or Ballard testing. It's guessing, it's not guessing, It's figuring out their gestational age based on their neuromuscular maturity and their physical maturity. And finding out if they're large for gestational age, average for gestational age, or small for gestational age. Those are the three things that you need to know about this. Question?
The percentage on the side, what does that mean? Like the 90, 75, 50?
Of all babies, what percentile does this baby fall in?
Oh, okay.
So just to clarify the three things, so neuromuscular, you said, I was trying to write them down.
Okay, let me. Gestational age. Is based on neuromuscular maturity. And physical maturity. And then are they small, average, or large for gestational age? And that's based on the chart? Of length, head circumference, and weight. And then this is called the Dubowitzer valve. Looking up a history in the medical record, this is just some terms that you'll come across. Okay. Let me give you the next handout so we can keep going.
Yeah. Yeah, that's right.
Oh, it's like the last time.
All right, ready to keep going? So this is talking about different neonatal diseases, and we're going to start off with respiratory distress syndrome. So who is at risk, and tells you the answer is premature newborns. So RDS in a nutshell is when you have infants that are born prematurely, the type 2 cells haven't had a chance to produce surfactant. So of course when they're born and not having enough surfactant in the alveoli start to collapse. So you'll see them beginning to struggle to breathe, and over several hours, their breathing gets worse and worse as the alveoli collapse. And now that makes for difficulty oxygenating, it makes the lungs stiff, so they have a hard time. So you start seeing signs of distress in them and poor oxygenation. So if they're born less than 28 weeks, 60 to 80% of the newborns will have respiratory distress syndrome. And it's caused by insufficient amounts of surfactant. The immature type 2 alveolar cells produce less surfactant. This increases alveolar surface tension and decreases the compliance of the lungs. And when you look at the chest x-ray, there's air bronchograms and ground glass appearance. So this becomes really important for you to spot on an x-ray. So I'll explain it. An air bronchogram is when you can see the conducting airways really well. And the reason that you're seeing the conducting airways really well is because the lung tissue around the conducting airways has collapsed, so they show up as white tissue, but there's still air in the conducting airways, and that shows up as the dark spots where there's air. So looking at this, for the trachea, you see the main stem bronchi, but then you can see the airways going even further into the lobar bronchi, and even into the segmental bronchi. I mean, you can really see the airways well. So when you see the airways well, because of the collapsed tissue around the airways, that's called air bronchograms. And then when you have a lot of atelectatic alveoli, they show up as little white dots, if you use your imagination. And that's called a ground glass appearance, and that came from it looking like somebody has ground glass and they threw it over the x-ray. All right, so this goes back many years. So, yes, ground glass appearance. And the ground glass appearance is, can you describe it differently?
I don't even know how to, I'm not sure if I know what it is.
I need to have a normal x-ray to show you, don't I?
Like a side by side.
Yeah, there's no normal ones to show you. How about it looks grainy? If you don't have many pixels on a camera and you try to enlarge a picture, it looks grainy.
I see what you're saying though, because it does.
How does that sound?
Doesn't look normal at all, obviously.
Yeah.
It looks very radio opaque everywhere.
Yeah.
Which is not normal. You shouldn't see it all. Like everywhere, we should see a lot of air, very radiolucent.
Yeah.
It's very fuzzy.
Yeah.
Fuzzy.
Fuzzy is a good word.
Hazy.
Hazy, yeah.
All right, fuzzy and hazy one day.
We're replacing the ground glass to fuzzy and hazy.
And that's also because of the collapsed tissue?
Yes. Yeah. Let me get my pencil to write down these words. All right, so treatment for these collapsed alveoli, first is nasal CPAP. The positive pressure that you deliver through the nose, it disperses throughout the airways, and a little bit of positive pressure may keep the alveoli open, and then you don't need part 2, which is delivering surfactant via the endotracheal tube. So sometimes nasal CPAP is enough. The positive pressure will keep the alveoli open, and surfactant will not be needed. So nasal CPAP would be the first go-to treatment. And then for surfactant, oh. All right, that came up. I'll come back to this. For surfactant, there's different types of surfactant. What's being used mostly right now is Curasurf, which comes from the pig.
Bovine.
Yeah, the cow, the cow looks happy because his surfactant isn't being taken from his lungs. I guess what they do is they, kill the animal, they grind up the lung tissue, and they can extract the surfactant from the lung
Really?
tissue.
That's special. That's very special. Doesn't seem like a good process.
For the cow?
Yeah, for the
Or
pig,
the pig?
or yeah, it's just not.
Yeah. A couple things about Curasurf is we'll go and visit the website. You have to know the dosage. I hear Ralph and Joy quizzing you guys a lot when you're doing your NICU rotation and you're with the newborns. They'll ask you, okay, what surfactant is typically given and what is the dosage? So you have to remember that it's 2.5 mLs per kilogram of body weight. So do you remember how to do that? If the newborn weighs a kilogram, how many mLs would you give? 2.5. 2.5, yes. So this website is put out by Curasurf, so it could be biased because they're going to say that their product is the best. But the way that they look at their product, the reason that it's the best is that it has more phospholipids in it, it has more dipalmitoyl phosphatidylglycerol, doesn't have additives, so they claim theirs is the best. And, all right, where did I find it? I guess the YouTube channel has a video put out by a neonatal therapist.
Curasurf, proactive alcohol, intratracheal suspension is intended for intratracheal use only. The administration of exogenous surfactants, including Curasurf, can rapidly affect oxygenation and lung compliance.
Which one
Therefore,
started?
infants receiving Curasurf should receive frequent clinical and laboratory assessments so that oxygen and
All right, so I'm not going to play any of these videos
Curasurf
because
should only be administered.
there's an extra credit for you. So from that same website, I copied this YouTube video. It's 50 minutes long, and it's a neonatal therapist from a NICU in Missouri, I think. Goes through babies that are born prematurely, what the problems are, proper ways of ventilating them to prevent any barotrauma. It's got a lot of good pointers. So I will give you 10 points if you listen to the video. Outline all the main points, like the more points you pull out from that, the more chances of getting the full 10 points. And you can submit it to me. I can give you 2 weeks to do it. When will your test be? Yeah, I think we have 2 weeks.
Because our test is
Do you want us to do that?
Yeah, the test for next Monday isn't on this stuff.
It's on previous stuff. And then
Yeah,
after,
so that's why I'll give you 2 weeks
got
to do this. Because you might be wanting to study for test 1 and leave this for after next Monday.
it.
So I'll make this due in 2 weeks. You have a question, Dina?
Do you want us to elaborate on what we're saying or just name things that they were talking about?
Because they're all done. Just name the things that they're talking about. So if they start off talking about RDS, and, mention the cause of RDS, because they go through the cause. Bagging the baby when they're first born. Best to bag with. They maybe mention, the pressure used. Then they start getting into surfactant, and you can explain how the surfactant is delayed.
Do you want typed, written, do you want?
Written is fine. Yeah.
Some people are specific what they want.
Yeah. Well, this is my first time assigning it, so usually when I give out an assignment and I don't get back the right results, I change it from year to year. It's like, okay, now it's got to be typed. But this is my first time doing this, so I'll see. If I can read your writing, I can give you credit. So if an infant is at high risk, premature delivery should be delayed as much as possible. So moms will be given tocolytics to try to stop the labor from occurring. Also, if it looks like they're going to deliver and they can't stop labor, it's good to give steroids to mom. Giving steroids to mom will go through and affect those type 2 cells and tell them to hurry up and develop and start producing surfactant. So if it's given within 48 hours before 48 hours of delivery, it will impact the type 2 cells and make them start producing surfactant. So the baby can be born prematurely and be fine because the steroids given to mom helped the type 2 cells to develop really quick. Do you need to add any notes to your slide on that? Got it? Okay. Which of the following are side effects of surfactant administration? And it lists some things. So before you look at the list, when you're delivering surfactant, it's going to change the compliance of the lungs really quickly. Like as soon as the surfactant hits the alveoli and starts spreading in the alveoli, the lungs go from being stiff to being compliant. So you'll notice your tidal volume returns are going to improve quickly. So there's always the danger that you could be over-ventilating and using too much pressure, and now the lungs are really compliant all of a sudden, and you can cause a pneumothorax, so that can happen. The surfactant is like the consistency of dish detergent. It's pretty thick. So when it's going through those little tiny airways, it can plug up the airways and cause desaturations during the delivery. So until the surfactant gets bagged in and makes its way down to the alveoli, it's plugging up airways as it's going. And that can cause desaturations, so that can occur. All right, so now you can look at the list. All right, what are some side effects? Pneumothorax.
Desaturation during delivery.
Oh, you guys are...
So,
All right, so both A and D is correct. You're faster than I am. Is it better to give surfactant to all infants born before 28 weeks gestation rather than wait for them to exhibit signs of RDS? Yeah, I would think so too. And I really struggled with this, trying to understand, why don't you just, they're born before their cells are developed, why don't you just give the surfactant? But they held off. And the studies have shown that if they go ahead and give surfactant to everybody, versus putting them on nasal CPAP and watching them for a couple days, there was no change in the outcomes of the baby. So they pulled off.
yeah.
I think there is, like 23, 24, 25 weeks, they go ahead and give it anyway. But it's not all babies born before 28 weeks. So yeah, I was amazed to find that out too. So it's false. Yeah, and then a lot of times giving the steroids to mom, it helps the type 2 cells and then they don't need surfactant. So that happens also. A 25-week gestation newborn appears cyanotic and with ABG analysis indicating hypoxia and hypercarbia. The infant has severe chest wall retractions with inspiratory effort. The amniotic fluid appeared normal at birth. What is the most likely cause of respiratory distress?
surfactant deficiency?
Yes, very good. The correct answer is A, surfactant deficiency. Question 2. An infant diagnosed with RDS subsequent to lung prematurity is receiving oxygen therapy with an FiO2 of 0.8 and nasal CPAP set at 10 centimeters of water. The infant is experiencing progressive hypercarbia and apneic episodes. That's not spelled right. They're appearing prolonged. Apneic episodes are appearing prolonged. The next logical course of action is to A, increase FiO2 to 100. That's not right either. And look for improvements in ABG parameters. B, start inhaled nitric oxide therapy to improve the lung VQ ratio. C, increase nasal CPAP to 12 centimeters of water. Refit the nasal prongs. Or D, intubate the patient and begin mechanical ventilation. All right, so one thing we know about nasal CPAP, all it does is help with oxygenation. It increases FRC, just like with adult patients. When you give CPAP, it does nothing to blow off CO2. The only thing it does is increase the FRC, and that helps to improve oxygenation. It does nothing to get rid of CO2. So if you have a baby on nasal CPAP and their CO2s are climbing, is more nasal CPAP going to help? No. They need to be ventilated. Intubated and ventilated. So experiencing progressive hypercarbia means their CO2 in their blood is getting higher and higher. So they need to be intubated and ventilated. What are the radiographic findings typical of a child with RDS? It should be infant with RDS.
Two, three, five.
Okay, so atelectasis from the alveoli collapsing. Air bronchograms, because the tissue around the airways is collapsed, so the airways show up really well. And the ground glass, hazy, fuzzy, grainy. Yes, so 2, 3, and 5. Very good. All right, so the next, we'll do one more, and then you guys can have lunch. Bronchopulmonary dysplasia, or it's called neonatal chronic lung disease. Let me just give you an overview of this. When you have premature babies and they're not doing well, you put them on a ventilator, so you intubate them and you're ventilating them with positive pressure